All right, I'm going to get started, Bernadette. Good afternoon. Welcome to the Reentry Initiative Advisory Committee meeting. If you could mute your microphone, because we have a lot of people in these calls. And I will be presenting today. I'm Deidre Manley with the Federal Medicaid Unit with the Nevada Health Authority, and Minden Hall will be presenting with me as well, who's one of my team members from the Nevada Health Authority. And then we will have two presenters from Manat, who is our contractor that we work with that really helps us with designing this waiver and working through all the logistics and everything. And they will have two presenters today as well. And they've presented at all the meetings, so you'll probably recognize them. We're going to go over some recap of our last meeting in July. These are just a high-level recap. And answer some of the questions that were asked that we were not able to answer in that meeting. Again, if you want to go back, these are all on our website, and our website is back up now, so you can go back and watch the full recording of these meetings and questions that were answered in those meetings, in addition to the questions we're going to answer today that we couldn't in there. And then I'm going to give an update on the implementation timeline for this waiver. And then today is really all about Reentry Initiative pharmacy requirements, so the mandatory services, and then additional services that our state has decided to offer. And then pharmacy enrollment in Medicaid. And then we're going to have questions and answers. So last time when we did this, we had a lot of questions that came up throughout the presentation. We're asking this time, please put them in the chat, continue to do that. But if you don't want to put them in the chat, you want to raise your hand that you have a question. Then at the end, we're going to answer all the questions at the end, and that'll help with time and, confusion, because it gets a lot of this is a lot of information, and it can be kind of confusing. So that's what we'll be doing. We also always have our website or our email address up that you can send us questions in as well if you're not comfortable asking in a big forum or something comes up afterwards. Next slide, please, Bernadette. All right, so again, please just keep your microphones muted. And if you could make sure that you're putting your name and your agency in the chat box, or if you're not with an agency, just who you are, maybe, your affiliation, or just you're somebody with lived experience, anything like that. That's helpful for us. If you're comfortable doing that. And then again, this meeting's recorded. We always send transcripts out after they're ready. And next slide, please. All right, so we've talked a little bit about the new provider type 98 Reentry Health Services. That is the provider type that was designed just for the reentry. It's now available for correctional facilities for enrollment, and that became effective on August 18th. So that is that provider type that is an umbrella for a facility. And then those facilities can have that individualized opportunity to hire, different providers in their communities that they want to work there. And a lot of facilities that we've met have very unique situations, especially in the rural areas. And so those providers can still continue to work for you. You're just going to have this, basically this umbrella, and then they come, you pay them, and then you bill Medicaid and get that reimbursement. So that is available now. It provides certain services for Medicaid eligible incarcerated individuals up to 90 days before their scheduled release, once the waiver is approved. This is once that 1115 waiver is approved. And then, but enrollment is available now through the Provider Flex tool. So this link in the PowerPoints, and we'll drop the link. Bernadette, if you or Richard could drop the link in the chat in case anybody doesn't have the PowerPoints with those active links. When you go in there, you can then sign up as a county, city, state government, and enroll on behalf of your detention center or carceral facility. And then an enrollment checklist is available on the enrollment checklist webpage. So I would, anybody who's going to be anticipating providing these services, I would encourage you to go ahead and start doing that if you aren't already. We do have some counties and state agencies that are already enrolled. And then a web announcement will be posted when the billing codes are extended to adults and youth in detention corrections facilities. So we are still working on all that with our Gainwell, and that we're working on it every week. So all demonstration eligible services delivered by PT 98 enrolled providers to individuals will not be subject to prior authorization requirements. I know that was something that has been asked a couple of times, so that's clarification on that. And next slide, please. All right, so this is just, again, just a high level, going over the questions that we were not able to answer in the last meeting, and getting those answers. Nevada Medicaid confirmed that MCO enrollment process for incarcerated individuals will align with existing MCO enrollment rules. So individuals incarcerated less than 60 days will maintain current MCO enrollment upon release. Individuals incarcerated more than 60 days will be disenrolled from their MCO and then eligible to enroll in an MCO prior to release via existing plan selection or the MCO auto assignment process. And because this is considered new MCO eligibility, the individual will be granted a 90-day plan choice period during which the individual may change their plan selection one at a time. If an individual is being released into a household that has an established MCO, they will be assigned to the same MCO as their family unit. Nevada Medicaid clarified that the reentry demonstration requirements presented in the advisory committee meeting apply to both individuals with and without known release dates. So for individuals who are incarcerated with unknown release dates, which is very common in the county jails and juvenile detention facilities, where the average length of stay is less than 30 days, Nevada is defining a short-term model informed by jail capacity to uniquely define service expectations based on the length of stay. So we are still continuing to work on that, and we hear this every jail we've gone out to. So this is something that is still being worked on, and also checking with other states what they're doing. Nevada Medicaid will clarify expectations through future operational guidance for expectations to meet medically necessity for court-ordered services and Medicaid enrollment for pharmacies. And then again, at the bottom, it's materials and recordings are available if you want to shoot us an email, and that's That's our email as well. If you have any questions today, that if you have to jump off the call early or you think of something later. All right, next slide, please. All right, so the update on our reentry initiative implementation timeline. As you know, we've brought this up many times. We submitted our waiver applications to Medicare and Medicaid services in December of 2024. And while awaiting approval, we have continued to move forward with policy design and operational planning. We meet with CMS, Medicare, Medicaid every week, or every other week. We initially anticipated, and CMS was pretty positive, that we would be approved by Q3 2025 and launching services in selected facilities by late 2025. However, due to competing priorities at the federal level and focus on implementation requirements associated with HR 1, the big beautiful bill, CMS has signaled that the waiver approvals may be delayed. And so we are still meeting with them. We meet with them again next week. Resultingly, Nevada Medicaid does not anticipate receiving waiver approval for the reentry initiative before the end of 2025, such that services will not go live until sometime in 2026, probably 3 to 6 months following approval from CMS. So that's the timeline we're looking at right now. In the interim, though, we continue to engage with CMS to develop standard terms and conditions for the waiver and we are preparing to submit the state's required implementation and reinvestment plans. We are going to submit those anyways, even without that approval. Nevada Medicaid also plans to continue to implement system upgrades and develop policy and operational guidance for correctional facilities, managed care plans, and community-based organizations participating in the reentry. So what does that mean in real language? The CAA is for our youth, and that is youth eligible up to their 26th birthday that have aged out of foster care, is that is a federal mandate. So that is still in effect and moving forward. What this means is our waiver is just, the timeline is pushed out. We were at the top of the list to be approved, and the people that we work with at CMS were really hopeful that that was all going to go through, and so this came down a week ago. And they still are very hopeful. There's still, right now, there's the reentry initiatives have a bipartisan support with 25 states pursuing them, and 19 demonstration waivers have already been approved by CMS and are actively being implemented. So there's no indication to date that the new administration will stop supporting states in their efforts to implement or pursue reentry initiatives. So we're sure this will be going through. It's just taking a little bit longer, and probably because there's a lot of states applying, and there's a lot of services in there that are needed. So that and it also, I guess the second part to that is that this also gives us more time as we are trying to work through all the systems. And for a lot of you that are going to be implementing this, and it's a heavy load, so it's giving us more time and maybe learning from other states as well. So that's how we're looking at it. Next slide, please. All right. And this is just a reminder, the key components of reentry service delivery. So this will be what we've already gone over, and then what is today's focus. So enroll in or suspend Medicaid coverage is that first step during incarceration. And then screen for access to pre-release services would be the next step. Provide pre-release services during the 90 days prior to release, including medications and case management. And then supporting reentry planning. And then providing medications in hand as needed and warm handoff to post-release case manager. So this is what we have gone over and what we will be focusing on today. And I'm going to hand this over to Minden.
All right, thank you. Next slide. Perfect. Okay, so the core objectives of pharmacy services are to ensure access to medications in the pre and post release period. Access to medications can ensure multiple concerns, such as continuity of care, preventative relapses, overdoses, especially for opioid and opioid use disorders, and the worsening of any other health issues. This ultimately can improve rehabilitation, reduce rearrest rates, and enhance an individual's ability to reintegrate into society. Tongue-tied today. If we could go to the next slide, please. So the scope of eligible pre-release services. Facilities must demonstrate readiness to provide the mandatory services that are listed in the green box on the left. We're going to focus on the ones that are starred today. And then later on in the presentation, this will be discussed more. But the first two stars in the green box, medication-assisted treatment, also known as MAT, with substance use disorder, which is also known as SUD. And then the second star, medications upon release, a 30-day minimum supply. And then additional services on the right in the orange box. The first star there, we'll focus on prescribed drugs and medication administration consistent with what Medicaid covers for such services. If we could go to the next slide, please. Okay, so a little overview of the mandatory SUD and pharmacy services. So up to 90 days prior to release, SUD clinicians do screening evaluations to look for verbal confirmation of a recent use of substances and or showing signs of withdrawal. The middle green box there for treatment will include access to appropriate SUD medications during pre-release period and in hand upon release. If clinically appropriate, access to psychosocial services such as counseling and behavioral health therapies are included. And you may be asking what happens at release. Facilities must ensure access to at least 30-day supply of medications in hand with a prescription for refill. Now, we'll go ahead and get into more detail. So next slide, please. And I believe I am handing this off to Sarah.
Thank you so much. So if you can take it to the next slide, I will walk us through MAT service requirements. So before I jump into the requirements for screening for SUD, we want to note that correctional facilities must provide access to a qualified provider who can evaluate, assess, diagnose, and prescribe treatment for SUD to participate in the demonstration. Correctional facilities can use an in-reach provider within the correctional facility, an embedded provider within the correctional facility to deliver the service, or they can use an in-reach community-based provider to come in and deliver that service within the correctional facility. And it's recommended that for clients who have verbalized recent use of substances or show symptoms of withdrawal, that these services are prioritized to support timely and safe access to treatment for these individuals. And what these kind of requirements include for assessment, evaluation, and diagnosis, the demonstration requires screening, assessment, and evaluation of health conditions, including needs identification, engagement in care, tools like recovery-focused motivational interviewing, and choice counseling for patients. It requires diagnosis of the substance use disorder. It requires provision of treatment as appropriate to ensure stability and control of chronic conditions. This is often referred to as medication administration. And it also requires recommendations for what pre-release treatment and services that the individual should receive. And that includes referrals to other providers for evaluation or treatment as needed. The last step of this is the connection to kind of post-release services, where there needs to be a warm handoff and a recommendation for services and treatments provided in the post-release, including potential areas for further assessment or diagnosis whenever the individual is receiving their post-release treatment plan. Nevada Medicaid supports the use of kind of any evidence-based screening tool for potential substance use disorders, and will develop further guidance on exactly what this will look like in collaboration with correctional facilities after learning more about current tools that are already used in correctional facilities, and really trying to align to existing practices to bolster existing tools and screening practices that we know work in correctional facilities. So more to come on that in this kind of broad umbrella of policy and operational work that Nevada will continue to engage in. Next slide, please. So getting into the SUD treatment requirements that will be required under the demonstration. Generally, the demonstration requirements include assessment of individuals who've screened positive for substance use disorder, treatment planning for those individuals, and then timely introduction of medication-based treatment or kind of continuation of medication that was prescribed in the community. So specifically for individuals with OUD or opioid use disorder, what this will require is management of opioid withdrawal with an agonist medication. And so this can be buprenorphine or methadone, whichever the correctional facility chooses, using evidence-based tools and interventions. So this must follow evidence-based practices and
call is no longer being recorded.
It must follow best practices, but correctional facilities are going to be given the choice to provide access to one form of an FDA-approved agonist medication, so that you don't need to provide access to both. It's whatever works best in the correctional facility delivery system that you have. And then under OUD, and this will be similar for AUD, is timely induction of an appropriate form of medication that's going to be based on the individual's preference for treatment, or timely continuation of medication that's prescribed in the community if they come in and they were previously receiving that medication. For individuals with alcohol use disorder or another type of non-opioid substance use disorder, these also need to be managed under the demonstration. And these need to be managed using evidence-based tools like medications and therapy as appropriate. All correctional facilities must ensure access to all FDA-approved drugs that are approved to treat AUDs and non-opioid SUDs. And those will be defined in policy and operational guidance and formalized in future development materials for correctional facilities, but providing high-level strokes of what is going to apply for all correctional facilities in today's presentation. So continuing on the next slide with the remaining SUD treatment requirements under the demonstration, correctional facilities will be required to taper or discontinue medications as clinically appropriate, determined by the clinician and the patient on a case-by-case basis. Correctional facilities just will need to be prepared for these clinical scenarios. And then we stress that psychosocial services will need to be delivered alongside medication treatment. And so medication should not be delivered in a vacuum as a best practice. Medication should be delivered alongside patient education, counseling and behavioral health therapies, and medication administration, of course, is clinically appropriate. If psychosocial services cannot be delivered, we still recommend that MAT is delivered. MAT should not be withheld from individuals. This is a required service under the demonstration, but as a best practice, psychosocial services are paired with MAT delivery. And then these final 2 points connect to requirements in the post-release period, where the individual that's providing MAT in the pre-release will need to have a transition plan for a community provider to deliver medication in the post-release. And then they will need to provide an appropriate supply of medication in hand upon release. And so we'll stress that this is determined as medically necessary. We know that the demonstration overall requires medications in hand upon release for 30 days, but that might not be clinically appropriate for an individual with a substance use or an opioid use disorder. And so this is as determined as clinically appropriate by the prescribing physician, but they will need to be provided a kind of an appropriate supply of that medication upon release. Which leads us into our next section. If you wouldn't mind going 2 slides on medications upon release. And so this applies more broadly than just medications for opioid use disorder, alcohol use disorder, or non-opioid substance use disorders. This is all medications that an individual might be prescribed or might be receiving in the pre-release period. So you'll see on this right-hand side, it stresses medications include all drugs that are FDA approved and are on the Medicaid drug rebate program or over-the-counter drugs that are eligible. And this is any drugs here still need to follow the preferred drug list and the Medicaid services manual. Kind of this yellow box in the bottom right stresses that these medications will be subject to existing prior authorization rules in Nevada Medicaid. And so to ensure that medications are available upon release, providers will need to ensure that appropriate prior authorization is obtained for those medications. So going through the left-hand side of this slide, as I kind of already alluded to, facilities must ensure access to at least a 30-day supply of medications in hand upon release. And the scope of these medications are the medications that are memorialized in Nevada's Medicaid state plan. Facilities should also submit a prescription for any active medications to the individual's community pharmacy as appropriate and feasible, alongside providing that supply of medications in hand upon release. And this really allows them to have sufficient medications whenever they are being released into the community before they are able to kind of establish their relationship with community providers to keep that prescription maintained. And so the obligation of pre-release case managers here will be to support access to medications in the community by developing this medication list that is to be provided to the individual upon release. And then if the post-release case manager is different, this list should be handed off to that case manager so that transfers and medication refills can be ordered as necessary. Next slide. So acknowledging that the description that I just provided is a very ideal state, Nevada Medicaid recognizes that an individual's timing of release is not always known. And there are several factors that may impact a facility's ability to comply with these requirements, such as scenarios where an individual is incarcerated for a short stay and has an unplanned release. If they're released directly from court and they're not released from the correctional facility directly, or there might just generally be insufficient time for the correctional facility to fill a prescription before that individual is released. So Nevada absolutely acknowledges that these are significant challenges to providing 30-day supplies of medications upon release, and is going to be developing future policy and operational guidance to really solidify the approach based on current practices in correctional facilities and kind of what is feasible. But at a high level, Nevada will define a short stay model that really defines a minimum timing requirement where the state understands that providing individuals with medications in hand upon release just is not feasible. So, for example, the number on the slide here is individuals who are incarcerated for under 72 hours. Just having the rule that says that if their stay is less than 72 hours, the state understands that it just is not going to be feasible to provide medications in hand upon release. State's still defining what that exact time frame is, but this will impact services like case management that has already been talked about at a prior meeting as well. But this will also apply to medications in hand upon release and MAT under the demonstration as well. And so next is the pharmacy access policy, and there is a 30-day fill requirement that pharmacies must follow when the individual is released during pharmacy business hours or after hours if it is expected release, such that the facility has sufficient time to coordinate access and fill of those medications. So this is an initial policy that Nevada has defined to say if the pharmacy access is feasible, if the individual is released during pharmacy hours, or if they are able to coordinate access for these medications prior to the pharmacy closing, if they're released after hours, it would still be expected for that correctional facility to provide medications. But of course, this individual choice option is available for when an individual is released and it is infeasible for the correctional facility to provide medications in hand to that individual at that moment. And so some options that Nevada is planning to provide to facilities is that the facility must provide the individual the option to either come to the facility the next pharmacy business day to pick up their medications or identify a community pharmacy that has access to the 30-day supply of medications that they can coordinate and support the transfer of that prescription to. Next slide, please. And so this is repeating a lot of the things that I stated while going through the policies on the last slide, acknowledging the challenges that exist related to delivering medications in the 30 days post-release, where unplanned release dates, individuals being released directly from courts or having insufficient time to fill prescriptions may result in correctional facilities not being able to provide access to this 30-day supply of medications. While it is an option that correctional facilities can provide the prescription to be picked up at a local pharmacy, experience in other states shows that this is less effective than providing medications directly in hand, because the individual will have several competing priorities when they're reentering the community, and depending on the distance and other factors that may impact their ability to access that pharmacy, the community pharmacy may not technically be accessible to the individual upon release, even though it is not geographic distance, a large geographic distance away. And then a challenge that we acknowledge is the prior authorization and preferred drug list compliance of medications may result in some challenges ensuring that those medications are available and accessible right as the individual is released. And so Nevada is going to continue developing best practices as they continue to work with correctional facilities and learn about existing practices and the ways that correctional facilities are currently providing these services. But some of the lessons learned from collaboration with other states include partnerships with community-based pharmacies, the partnership with mail order pharmacies, or the use of courier services can help ensure medications are available upon release for correctional facilities. Facilities can also strive to give medications to individuals as keep on person where possible. And so when they're having a short-term stay and you anticipate they will have an unplanned release date or could be released at any moment, if there's an opportunity to have a keep on person medication, and so they will automatically then have that medication whenever they are released, is a way to kind of mitigate the potential unplanned release and lack of medication that would be accessible then. And then as a potential to improve fill times, facilities could issue 2 prescriptions for medications, one as a kind of keep on person while they're incarcerated, and then one as a prescription that will be accessible to them when they are released from the correctional facility. And I will, I think, turn it over to Deidre for pre-release medication requirements.
Thank you, Sarah. All right, pre-release medications. So optional service correctional facilities may provide is by either correctional facilities and or community-based provider to participate in the reentry initiative for pre-release medications. Next slide, please. And some of these are on the right-hand side. Sarah has already gone over these 2 boxes that they apply as well to the pre-release medications. So medications that are FDA approved and participate in the Medicaid program, and then as well as family planning medications administered at release. And then the prescribers must follow Nevada Medicaid rules regarding prior authorization and list of medications that are listed on the PDL or the MSM, Medicaid Service Manual. So with pre-release medication requirements, facilities that opt to provide pre-release medications, and this is an optional service, must ensure timely continuation of all FDA approved medications that the individual was previously taking. So for example, prior to incarceration for shorter incarcerations, prior to a 90-day period for longer incarcerations. Provisions of existing medication therapy for continuity of care should occur for the 90-day pre-release period as clinically appropriate or transition to a covered medication. And facilities are required to ensure the client receives the next scheduled dose unless otherwise ordered by the prescriber. Next slide, please. And then pharmacy enrollment requirements. Pre-release medication processing responsibilities as to provide medication in the pre-release period and upon reentry, correctional facilities must ensure the use of a licensed, registered, Medicaid enrolled pharmacy to dispense covered outpatient pharmacy medications, the submission of pharmacy claims to Nevada Medicaid, and the support of prior authorization process for any medications requiring a prior authorization. Next slide. Right, I think this is you, Minden.
Thank you, it is. So I know you're asking who can enroll as a Medicaid pharmacy? Any jail, youth, correctional, or prison facility with a licensed outpatient pharmacy on site. Please note, if a location has multiple on-site pharmacies, Only one pharmacy per site is required to enroll. Also, any licensed outpatient pharmacy located in or out of state. The how and where to enroll is on the Nevada Medicaid Provider Flex portal. I know we talked about it earlier, but I'll go ahead and drop another link in the chat if you want to check that out. And then that's it for this slide. So I'm going to actually pass it off to Deidre again, and we can now have time for questions.
Right. I don't, Richard, do we have any questions in the chat?
There's no specific questions. There's one comment.
Okay. And what was that?
It was from Jess Angel. Maybe the facility should take into consideration the times they release individuals, so it would be more effective at assuring that the medication can be accessed.
Okay, we will definitely put that in our information, and I agree as we've been out there going to all these different facilities and all over the state. That is definitely a challenge, and it's brought up quite a bit. So thank you for that.
And Stephanie, you have your hand up. You want to go ahead and go? There's a couple more questions in the chat we'll get after.
Okay.
Yeah, this is Stephanie Cook with Division of Public and Behavioral Health. I just had a couple questions. So the provider type 98, is this a group enrollment? It sounds like the facilities can collaborate with other community organizations. So is PT 98 a group enrollment that only the correctional facility has to enroll, and it does not entail enrolling individual practitioners?
Correct. So think of it as an umbrella over your correctional facility or that location. And then we designed this so that we're not telling you, you can't use that nurse anymore, you can't use this pharmacy anymore. The facility will be responsible to make sure that they are qualified and licensed and everything, but the facility can use whoever they choose to hire. They will still pay them, and then they will bill Medicaid.
Okay, and then my last question, and then I'll turn it over. But so you talked about the SUD screening and assessment. So I'm just thinking of perhaps a prison setting to where maybe that screening and assessment was already done months ago, years ago, and possibly hasn't changed as someone enters a correctional facility like a prison. Like the history doesn't expect to change on somebody. So when you say that that's required, will you look at past assessments like that, but by the time someone entered the correctional setting, or are you requiring that a whole brand new assessment and screening is done 90 days pre-release?
If the correctional facility wants to bill for the service that was provided, it will need to be provided in the 90 days pre-release. But if they want to use evidence of the services that they had already screened for, have evidence of the provider is eligible to say that the screening was already conducted and the clinical condition of the patient has not changed. It just, if it's outside of that 90-day period, billing will not be able to occur.
Awesome. Thank you.
Thank you.
Okay, we have a couple more in the chat. This is from Neville. Who is responsible for providing medication pre-release and at discharge? Correctional facility pharmacy or community outpatient pharmacy?
I can take that one, if that's all right, team.
Yep, go ahead.
Yeah, so
Please.
Nevada is going to be taking a correctional facility informed approach. And so this will depend on the capacity of each individual correctional facility that's participating in the demonstration. If they have an on-site pharmacy that is able to participate in the demonstration and provide these services, the correctional facility will be eligible to use their own on-site pharmacy. If they don't have physical space for that pharmacy, if they don't have one on site, the correctional facility will be expected to then partner with an outpatient community pharmacy to provide medications pre-release and post-release.
Okay. The second one is from Magdalena. What happens if a youth is released unexpectedly outside of pharmacy hours? How will families still get access to needed medications?
Yeah, that's a great question.
Yeah, that is. And Sarah, I think you kind of went over that in one of your slides, right? Do you want to recap it? Okay.
Absolutely. So if an individual is released whenever the pharmacy is closed outside of hours and it's unexpected, kind of two scenarios where the two options the correctional facility can choose. One is that the individual is provided the option to come back to the facility the next day as soon as the business day starts to pick up their medications directly from the correct medication or from the correctional facility pharmacy. If that is unavailable, then the correctional facility is required to identify a community pharmacy that is able to provide access to those medications at the time that that individual is released and transfer the prescription to that pharmacy, even if it's not the one that they've otherwise been participating with through the demonstration. And so it very likely will be the kind of coming to the facility the next day, right at the start of the business day, for these individuals that are released outside of business hours. But Nevada will absolutely collaborate with correctional facilities to further define this guidance and understand how this works in practice.
All righty. So one more question from Neville. How will correctional facilities confirm post-release 30-day supply of medications were picked up if picking up from community-based outpatient pharmacy? Is there a feedback mechanism?
That's a great question. I don't have a definite answer for you, but if care coordination is happening and they're using maybe the same care coordinator, I would hope that that care coordinator would be helping with that. If you've got one care coordinator inside the facility and then one on the outside, again, best practice is that they're working together and coordinating all of that and providing that information.
All right, that's all I see right now in the chat.
Okay. Well, thank you, everyone. We have such good participation on these calls and people coming. Please feel free to share any of the links with anyone that might have any interest in this, as well as I will be up on our website. This is recorded. It will be live on the website probably next week so that people can go back and watch any of this. And then our next steps, I'm going to hand that off to Bernadette or to Minden, sorry. And thank you again for your participation.
Great, just a few more things, we're almost done. I'll drop in the chat. We've created a survey that we'd like you to take some time and answer for us. It'll give us, it's covering everything that we covered today, and it'll give us a little more better idea of needs, concerns, and even wins that you've had. So let me paste that here. And then if you see here, our next meeting is November 18th, and we'll be covering providing other covered services. I thank you all for attending and have a great evening.
Actually, there's a couple left in the chat, or a couple in the chat still.
Okay.
Real quick,
Thank you.
from Jess, I really feel that making people wait to get medications puts them at risk. This could be risk of overdose, reoccurrence of use, etc. And then also Neville has, who would be the best person to contact to follow up with additional questions?
That would send that, if you could send that to our 1115 waiver email, and we will make sure that your questions are answered and by the appropriate people. So I believe that is in the chat. If not, if somebody, Bernadette, if you could drop it in the chat, it's also on these slides. Do we have any other questions, Richard?
Yes, from Magdalena. This just came in a couple seconds ago. What plans are there in place to address language access for families who do not speak English as their first language?
That's a great question, Magdalena. Hi, Magdalena. Well, that is with the facilities, the providers that they contract with. I know when it comes to with signing up for Medicaid with DWIS, which I believe the name has changed, Department of Welfare and Supportive Services. They do have people that can speak other languages, as well as access to programs that can help with that. But that's a great question, and we will get back to you on that.
All right, that is all I see right now.
Okay. If anybody has any other questions, please send them to that email, and we will get you answers back and make sure they get to the right people and you get the answers. Sometimes it's not till our next meeting, but if we can, we will get back to you, within the next week with answers and any other feedback. So thank you all for your feedback and great questions. Good night.
Thank you.
Thank you, Sarah.
Thank you so much.